Live? Are we live?
I
Do you
don't
get the
know.
notice on your phone? Are we live? Let me check my
It's
phone.
been so long, Haney. I don't remember
I
what it feels
know.
like.
I don't know what it feels like to be live anymore. Yes, we are. We're absolutely live.
Oh, there we go.
All right, cool. So, welcome. I'm going to adjust my frame a little bit while we get started here. We had a last minute shuffle of things, and we won't go into the details, but you may have come here to talk about mechanical thrombectomy in pulmonary embolism. And what we're going to tell you is you're not going to hear that tonight. That's all we're going to say. But first
Our
and
our
foremost,
expert our expert is such an expert that he is currently doing mechanical thrombectomy for pulmonary embolism, so
that
he can't speak to us, right?
that's exactly what happens when you're expert. Then you just get called in, and that's that's the rub. But anyway, Adam, it is good to see you. How was your Thanksgiving holiday?
It was great. I worked, and so generally what I do is I
It
try
was
to
great.
eat
I
as
worked.
I try to eat as much possible cafeteria Thanksgiving food as I can,
I'll be honest with
and
you. I'll be honest with you. People lament working the holiday. If you can convince your family to be okay with it, it is the best time to work. Absolutely the best time. There's so much food between the potlucks and everything. Then the hospital throws food at you. It's the most wonderful time of the year, as they say.
yeah, it's actually interesting. We could probably talk just about this when you think about different careers in medicine, and you and I are shift workers, right?
Yeah.
So as shift workers, oh, I'm gone. Oh,
Nope,
I'm
you're
back.
back.
As shift workers, we have to we work nights, we work holidays, like there has to be there. So I have decided that I work at least two holidays a year, and those holidays are Thanksgiving and New Year's, and that's the way it is every year.
Yeah. Yeah. I think most shift workers know there's like, it depends where you work, but there's like 6 holidays, and you're going to work 2 to 3 of those holidays. And like I
Yep.
said, if you work the holidays that serve food, then you're good. You're smart.
Yep.
So we had a contingency plan here, Adam, didn't we? We knew this could be a
Actually,
possibility.
Actually, can I give you a surprise first? I've planned a surprise for you.
For
You
me,
ready?
yeah.
Yeah.
Yeah, I'm ready for a surprise. This never happens. I never get anything. I'm going to keep my expectations even tempered. But if it's a key to a Lamborghini, I won't be upset. Oh, excuse me. That is fully dope. I love it. That is an official. That's an official resuscitationist, critical care everywhere hoodie. I love it.
Yep. I love it.
Nice, man.
So I just wanted to say thank you. And I hope
My pleasure.
everyone is checking out Recess X. It's
It's
bomb. I don't
something.
know what else to
It's
say.
something. It's
Yep.
something. But thanks for the plug. I appreciate it.
Yeah. So what are we talking about? We are going to talk about VV ECMO.
Hmm.
So, and not only that, I thought it'd be fun. This will be a shorter lounge, and there's so much to talk about. There's so much literature. Everyone's so into ECMO right now, and I thought we would talk a little bit about my practical approach to managing the ARDS patient on VV ECMO. And we should say that what 90% or plus of patients that go on VV, it's for ARDS, and they're so you're asthmatic, the pulmonary embolism that just needs VV. There's other indications that the approach might be slightly different, but I thought we would just fixate a little bit on ARDS and VV.
I love it because we spend so much time talking about how sexy it is to get people on ECMO, and then the conversation, the lectures, they usually die after that point. But I think that people sometimes gets lost in the nuances of how do you manage that patient after you start cannulating them, or you're a couple days into cannulation. What do you do? So I'm really glad that this is what we're going to talk about. And let me just go ahead. Let me start you off with a question, okay? So
Yep.
let's say you've made the decision. The decision been made. You're cannulating the patient for ARDS. Um, Tell me, what the time course is for these patients as you look at this person, you zoom out. What is your expectation for this person's management over the next days to weeks?
Yeah, that's a great question, and I think uh, I'm gonna quote Emily Damath, one of our intensivists, and she always says the decision to cannulate and the decision to decannulate are by far the hardest parts about ECMO. So once you've made that decision to cannulate, you kind of overcome the biggest hurdle. And I think there's really in my mind there's three stages of ECMO, and I know we're going to get into each one. That first stage is converting the patient once they're cannulated from those typical ARDS vent settings, which we'll go over, to a more lung safe, lung protective approach. And there's a lot that is a very important, very intense stage, where you really have to think about the physiology, the gas exchange, what's going on with the vent, what's going on with the patient, and we'll go through that. And the second stage, that's like the cannulation stage directly after. The second stage is, I'll say, just kind of the maintenance stage. You're just waiting for those lungs to recover. And honestly, this is where the key here is probably all those non-sexy parts of critical care. And I love this stage. I think there's so much nuance in what we can do to make them better, but it's really about patience. And we'll jump into that, I'm sure. And then the last stage is, how do you get them decannulated? And that kind of switched from, I'll say that switched from lung protective to more ARDS vent modes and what that entails.
Right. So let's go into it, one by one. So the first stage you said is the cannulation decision. Um, let's talk a little bit about that. What we should talk a little bit about what goes into your decision for when you're going to put the person on. Certainly, we all know that Adam Green is the prone master, and he loves proning early. But despite that, if a person's not responding as well, when are you making that decision? What are some key things? And we'll go over this quickly because I think majority of the audience gets this, but I do want to get into your brain and see what makes you tick.
Oh wait, so this is just, you're asking just like we've cannulated them, not what am I thinking about? Or are you asking, am
Right
I
before
prone in all these
cannulation.
patients on ECMO?
Well, let's start off with the decision right before, and we can be brief about this, and then we're going to go into the person who is already cannulated now, and then what are the next steps for you working on the vent, deciding to prone. So take me to the steps right before. What are some of the things that tell you that this person needs to be
Oh,
prone?
I
A
understand.
review of sorts.
Of proning. I'm sorry, of proning. Um, so,
Yeah, I would say, why don't we talk first before we go into proning? Let's talk about which patients you'd consider to put on ECMO.
oh, okay, good. So, there's pretty strict criteria in terms of who goes on ECMO. I am going to be a little vague because I am of the belief that these criteria are going to change. I think uh, COVID and the ARDS pandemic we've had has shown us that I think ECMO is less exotic than we want it to be. And if you have the resources and the perfusion support, I think we should be putting more people on ECMO. And I believe that. Um, but strictly speaking, I think about, do we have the patient? So if I'm getting a call from a transfer center and someone says, I have a guy on ARDS and I think they need ECMO, these are the things I think about. Number one, comorbidities. So if they have any chronic organ failure, that's generally a no-go. So that is patients who's cirrhotic, that's a severe cardiomyopathy, and I know that's a little vague. That's a dialysis patient. These are patients that usually don't qualify for ECMO. Now, I think that's a little can be a little bit soft in that I've certainly cannulated someone who is a dialysis patient who had a massive aspiration event or a drowning event, and I think this is a quickly reversible, and they just need a couple days of ECMO, of VV support. So that's a different scenario, but for the most part, those are out. Secondly, length of mechanical ventilation. So this is a hot topic. The guidelines say 7 to 10 days. Whether you believe non-invasive support prior should be counted. That's up to you. I take it into consideration, but it's also, once again, a weight of how reversible I think it is, how young they are, what the other factors at play. Third is age. Age, generally speaking, is 65. If they're over 65, we tend to not count them for VV ECMO support for ARDS. Have I broken that rule? Of course I've broken that rule, but that's generally the cutoff. And then we think about what's their gas exchange. And this is the real kicker. So I want to hear that the patient's been on maximum vent support. So what does this mean to me? This means lung protective, 6 cc's per kg, appropriate PEEP. So don't be calling me with someone who's got a PEEP of 5. No wonder their PF is bad. And then proning. That usually goes along with full vent support or full vent control, I'll say, which I guess is synonymous with neuromuscular blockade, but that could be debated as well. And I like to see that they've been proned a couple times.
Okay.
I don't want EPO. I don't know if you believe in it. I think if they have right heart failure or you need it for transport, I'm all into pulmonary vasodilators, but I don't want that in my criteria. And then I look at the PF, right? And if it's less than 70, they're a candidate.
Gotcha. And I want to bring up the proning thing because I've heard this out there in the wilderness where some people say, well, if I prone them, I'm going to push them a couple extra days and potentially
Mm,
put them over that 7 to 10 day mark. So I don't want to prone them because I'm just pushing them further out. But I, I think you can take a position on either side. I'm hearing you saying, no, you do want to prone the person. You want to give this person the maximal benefit because that's part of the maximum care. Is that right?
right. So, uh, part of my response is going to be think about physiology. And so if they have ARDS physiology and you see the trajectory is potentially going to need ECMO, then please prone them early. Don't wait for that PF to drift down to 150 before you prone them. So you should never be in that scenario, right? And secondly, we should avoid ECMO. And if that prone session, we've all seen the miracle prone, right?
Yeah.
Where you like do it and all of a sudden their PO2 is 300. Like that's what we should be doing, not
Right.
just putting someone on ECMO.
And I think that kind of goes along with the Caesar trial when you talk about, getting someone out of the community, small hospital where your outpacing resources, where maybe they can't prone, get them to the major center where ECMO is available, but we can do all the other things. And you're right, we've accepted transfers who are like, this person might be prone, might be an ECMO candidate. You prone them, and it's like, yeah, no, they're actually doing excellent, and we've
Yeah.
stayed away from ECMO. So ECMO is sexy, ECMO is cool. We should try not to do ECMO whenever possible. Cool.
Yep.
All right.
Absolutely. It's the
So
BMI, right?
yeah,
The morbidly obese patient that can't be prone to the outside hospital comes to us. We prone them, and they magically get better. Like
exactly,
we've seen it for sure.
exactly. All right. So take me through. We cannulate. We've made the decision. Take me through the vent support. Your initial settings, what your mindset is when you're picking a mode, respiratory rate, like all the things that go into that decision of setting the ventilator as well as the ECMO circuit.
Yeah. I love this. And we could probably do a talk just about what size cannulas and where we're going to put them, but let's maybe we avoid that for today. Um, but we've decided, we've picked our targets. I don't always heparinize on cannulation. I don't always heparinize for VV, but I think about it. It's a weight based. It's not a standard dose. And so then you've cannulated them, and this is what I think about. So I need to make the vent as safe as possible. The problem, and so how do I do that? Let's make the assumption that they're on typical ARDS vent settings. So we'll say 6 cc's per kg, appropriate PEEP, that driving pressure 16 or less. They're going to be a high respiratory rate because there's going to have some sort of respiratory acidosis that they're combating, right? And then you cannulate them. So what I do is I look at what I'm really worried about is dropping the PCO2 too fast. That's been associated with neurological injury, whether it's stroke, hemorrhage, et cetera, et cetera. It's been routinely shown that that quick drop in PCO2 is associated with worse neurological outcome. So I'm obsessed with what that PCO2 is. And just think about it, right? You have them on some crazy minute ventilation because their lungs aren't working all that well, of 14 liters per minute. You put them on ECMO, and you don't really realize, but the perfusionist has to sweep at 5. Now, all of a sudden, they're 19 liters per minute, fresh ECMO circuit, the PCO2 will plummet. So the way I try to avoid this is I look at the minute ventilation. Let's make a number up. I said 14, so we'll stick with 14. And then I look at the sweep. So if the sweep is 4, then I will make the minute ventilation 10. And I generally do that by reducing the tidal volume. So they're almost always for us on volume control. So I leave them on volume control to start, and I drop that to that supra protective settings, 4 cc's per kg, whatever I need to get that minute ventilation down to 10. Then I'm going to get a gas, and then I'm going to see. And of course, I should say, Kenny, I should always say, like, we got to think about what the pH is. Like if we're like danger zone and the pH is 6.9, all right, we're going to push it a little bit, right? But then we get a gas, and we slowly sequentially, maybe 30 minutes, 20 minutes, we slowly sequentially switch get the respiratory rate down. And my settings are pressure control 15/10, respiratory rate of 12. That's what I put nearly everyone on. But it may take a couple hours to kind of safely move to that direction.
So that's the goal. But again, being cognizant of looking at the pH initially and saying we may not be there just yet, correcting the acid base status, and then your goalposts are 15/10 in pressure control and a respiratory
Yep,
rate of 12, right? Okay.
that's right.
Okay.
That's most patients are managed on that.
Okay. So then tell me what's next. Now this person is cruising. We have the minute ventilation set. The ECMO circuit is doing what it needs to do. The person's on ultra low tidal volume settings. What are the next steps for you in the coming days, or what are you doing in that period, physiology wise? You diuresing them down. Give me a sense of what the package is for that patient.
All right. So yeah, great. So let's start with just the vent. So pressure control 15/10. PEEP never goes below 10 on ECMO. It's always 10, and pressure controls at 15. And I don't care what the tidal volume is. The world of ventilator-induced lung injury is a complicated, fascinating world, but I break it down into three types of trauma. There's volutrauma, barotrauma, atelectatrauma, and I want to avoid all three. And the vent is entirely designed to do that. So volutrauma, we're always going to have super protective lung settings. I'm letting the lung recover. I just don't want to damage it. So if the tidal volume is 70, fine. If the tidal volume is 40 and the vent won't stop alarming because a minute ventilation is less than 1, that's fine. I'm not worried about it. As long as the tidal volume is safe, there's no barotrauma on 10/15, right? Because our driving pressure by definition can't be more than 15. And then there's no atelectatrauma because I've got some PEEP going. And I don't worry about hypoventilation. I leave the rate at 12. Don't push the rate to 20 to have, whatever 70 cc's times 8 is more minute ventilation. Just leave it at 12. Let the ECMO do the job. That's what I do for the vent. Does that answer your question for that?
Absolutely, absolutely, and I think that's very helpful because the common questions that people ask me are, how do I titrate the vent and the ECMO? They're both kind of doing the same thing, and you answered that perfectly. You pick a setting that is ultra low, let the lung heal, and let the ECMO circuit do the rest. Before we go on to the next point, I want to ask you, because I mean, you talk to all the centers and you're really immersed in the literature. There are some places that will actually not do anything for the lungs, right? Or they don't even tidal at all. Is that right?
Explain, like they
Well, they'll just basically keep the tidal volume as close to zero as possible. I've even heard about some places extubating right when they're on ECMO.
yeah.
Is that something that is falling out of favor these days?
No, I think it's that kind of gets into the next stage of like the other aspects I think really contribute to their well-being. And yes, I think if there's a patient who's able to protect their airway, pull the tube out. Positive pressure ventilation is bad for the lungs. It's just bad for the lungs. So if you can get them on uh, just breathing naturally on their own, that's going to be the key. And like the steps to do that are complicated, right? So number one is sedation and paralytics. And this is my wheelhouse, and this is all I obsess over as soon as they're on ECMO. And I usually want that paralytic off within 24 hours. I just want it off,
Right.
or at least as low as you possibly can. And even cut the sedation, wake them up, let them spontaneously breathe. Even if there's some uncomfortable and they look terrible, like let it happen. As long as the tidal volumes are safe and there's not horrible desynchrony, I really push to get them off those drips. And you'll see just stopping the paralytic, even if they look the exact same, that tidal volume will go from 70 to 150 and the lungs will start to open up again. It's miraculous.
So your thought is that even the acute phase, when their lungs are still relatively sick, if you can take away positive pressure, let them breathe, let them have that negative intrathoracic pressure, open up their lungs because they'll do something,
Yep.
and then you're mobilizing them, they're walking around, they're doing all the other good physiology things besides the lungs while their
Yep.
lungs are healing.
Yep.
Okay. All
Yep.
right.
Absolutely.
Go ahead.
I was gonna
Okay.
say walk them.
Mhm.
You can do IJ Fem. You can get them in chair position. We
Yeah.
have a pretty standardized protocol where if they can sit in chair position for multiple hours, then we go ahead and we just get them on sitting on the edge of the bed. We walk. I've heard of patients with dual, with fem cannulation approaches still walking. Like that's not the patient's fault. Like don't if it's part of their recovery, find a way to secure those cannulas, obsess over it. Trust me, I'm in there like holding the cannulas, watching the patient the entire time, but like we're getting them and we're moving them.
Right. I mean, for I'm not giving a shout out to myself, but I'm like on TikTok and the algorithm just feeds me like ECMO videos of people who are up and ambulating. I mean, some of them are endotracheal intubated, and there's one person who's just walking with their tube, and it's almost like there's just no excuses. Like, okay, time to
Totally
work,
agree.
time to work now, and I love that attitude and the vigor, and that you can see in the patient's eyes because one of the things that I've seen in critical illness, whether it's ECMO or anything else, is there crosses a certain threshold where that patient's laying in the bed and emotionally they're done. Emotionally they're weak. But I
Mm-hmm.
imagine if day one or day two, you're like, there's no rest here, buddy. Get up and walk. That is just part of the constant healing and,
Mm-hmm.
everything else that goes with that package. Awesome. All right. Tell me a little bit about hydration, dehydration, uh, aggressive volume depletion. I think people hear a lot of different messages when it comes to drying out the lungs. I want to hear your protocol, your thoughts, what you follow, or do you just dry them out till they can't be dried out?
So I think we should like I wish there was some clever name for like the daytime. It's like daytime furosemide, nighttime albumin cycle, right? Where it's like whenever we dry out during the daytime, they start chugging and the cannulas are chattering all over the place, and then they just load them up with albumin again,
I
and it's
heard
this like
it's Lasix rises in
perpetual.
the east and sets in the west is what it is.
Yeah, that's exactly right. That's exactly right. And so, look, first off, it matters about what the right heart's doing. If the right heart's in trouble, then I'm gonna push volume removal a lot faster. If the right heart's hanging out and we're okay, I kind of just want the ECMO to flow smoothly, and I prioritize that. Now, obviously, if they're 15 liters positive, then I'm pushing towards euvolemia. But I usually, for those patients where the right heart's good, I don't think they're way overloaded. I'm gonna shoot for euvolemia, maybe a little negative, and just try to ride it out. But of course, it's patient to patient. But that's usually what I do.
And let me ask you,
Um,
because I'm sure someone's going to ask this, but what is euvolemia for this person who's ill, laying in the
yeah.
bed? How are you assessing that?
I guess I should have said net even is what I
So
meant to
just by
say.
the
So
numbers,
what
just by the numbers.
by the numbers, what's going
Right.
in. Now
Right.
you're going to go in and you're going to see that there's a peripheral edema and you're going to know that there's more. And then I may push the diuretics a little. And it's a trial, right? Some patients can tolerate those diuretic doses and they never have any chugging. If
Mhm.
that's the case, keep doing it. Their creatinine stable, their BUN stable, but you're going to see that bicarbs start to go up, their BUNs start to go up. And that also causes a problem, right? Because as the bicarb goes up, the PCO2 compensates and starts going up, their respiratory drive gets all messed up. And then as you're trying to wake them up, you're just in this
Yeah.
horrible cycle. Um,
Yeah. So you're
yeah, we
fighting
didn't
you're
actually. I didn't even talk about that. That's something actually really interesting too. When you
Yeah,
talk
go
about
ahead.
waking them up, is the intentional respiratory alkalosis. So where you drive their PCO2 down to 30, 35, their pH up in the 7.45, 7.5 range, and then when you almost like cut the respiratory drive. So then when you stop the sedation and the paralytics, they have a less desire to fight the vent, and they kind of let it happen. Certain diseases tolerate it better than others. ARDS is usually the least tolerant, but it's really an amazing phenomenon where you can like turn the sweep up and almost make them go apneic.
I see. So, walk me through that a little bit more. Are you saying that you would let them ride up a little higher, or that's something you're looking
Mhm.
for to bring them down?
I increase the sweep to drop the PCO2 into the 30s so
Gotcha.
that they
Okay.
have less of a respiratory drive. Yeah.
Understood. Okay, cool. Um, I just want to, something that I always hear when I'm rounding after you on the ECMO patients. I want you to walk through this line because I think it's a very clever line. 70% and flowing is the goal. What does that mean?
Yeah, yeah, 70s and flowing. That's what I
70s
say.
and oh,
Because they
70s and
always
flowing.
it 70s and flowing. Because what happens? Like you wake them up, they bear down, right? And then or maybe even they're just a little desynchronous and then their sats drop. or they like turn that, the nurse has to turn the patient. We got to do patient care,
Yeah.
and the sats plummet, and it takes a long time to recover. And it's like, so what do we do? Do we paralyze this patient?
Yeah.
Like, I feel like, I don't know. I feel like we're working backwards when we're doing that. Do
Yeah.
we just increase the flow up crazy high? Um, with that maybe your oxygen is going to go up, but so is your hemolysis, right? Your tendency for hemolysis. And so, yeah, if it's flowing and they're sat in the mid 70s, I'm okay with that.
70s and
Like,
flowing.
we'll
I
get
like it.
there.
Yeah.
I should say though, as long as like there's urine output happening and the
Of course.
lactate's not climbing, like as long as there's clear end organ perfusion happening, I'm good with it.
Right on. No, that makes a lot of sense. So you're looking for other markers of physiology to make sure everything's in homeostasis, and then you'll tolerate that rather than reacting to that and causing potential harm, putting you backwards. And that makes perfect sense. Speaking of which, we didn't really talk about the setting of. We talked about sweep. You didn't tell me about the liters per minute. Where you come up with that on the
So we
ECMO.
talked about
Sorry.
sweep. Yeah, flow. On flow.
Yeah.
So what do I think about with flow? A couple things. Number one, you know, if they're not anticoagulated, I like the flow to be, this is kind of made up, but higher, maybe at least 4. And I don't I'm a lot more, I should say, I'm much more afraid of bleeding than I am of no AC for VV.
Mm-hmm.
So we very frequently stop anticoagulation, and I'm okay with that. Um, but I keep the flow pretty high. And then in terms of how high I go, I think some of it depends on the date of cardiac output, right? So we had a beautiful case, big guy. He became septic, like 6'2". He became septic, and we put him on in ARDS, and we put him on, and we just couldn't get the sats up, and we measured his cardiac output. His cardiac output was something like 9 liters per minute, right? And so that's hard. That's 9 liters a minute going through the native pulmonary circulation, which is sucking right now. It's ARDS on ECMO. It's not contributing to gas exchange. And then so then the like 4 liters per minute of the ECMO machine just can't keep up with it. And so those are the patients I may increase the flow to try to compete with the native cardiac output. Does that make sense? Did I explain
Absolutely.
that well, or do I
Yeah.
need to?
No, no.
Um,
And I assume you're using ultrasound at the bedside to assess your
Yep.
cardiac output, right? Yeah.
Yep.
Perfect.
BTI and doing it that way.
Fantastic.
Absolutely.
Yeah, we should do an episode on that, on hemodynamics using ultrasound. Bring some of the fellows on because
That'd be great.
what we do at Cooper is amazing with regards to assessing hemodynamics of the heart. I think some people listening to the show have no idea just how good some of the people are at the bedside using ultrasound to assess
Yeah.
hemodynamics. Okay, next question I want to ask you. Tell me about proning. When do you consider proning? And any special considerations? Of course, the cannulas are a consideration, but just walk me through the decision to which patient should be proned. Because if your 70s and flowing, when is it a bad thing to and decide to prone somebody?
So these are like the my two loves competing with each other, right? So my one love says you should prone these patients. Their PF is clearly in the range. They physiologically would benefit. You should be proning these people. We should be cannulating, confirming cannulation, making sure that the gas exchange is fine, and then just flipping them over immediately. And I think there's a lot of sense in doing that. And there's some small studies, but at least one I can think of that shows clear benefit for proning in ECMO and survival mortality benefit. However, the second love is saying wake them up and mobilize them. So I think you just have to decide, like, how acute are they in the process? Is there a benefit? Like, what else is happening? Maybe there's sometimes they're in shock and there's hemodynamic reasons you shouldn't. Maybe, I don't know. You just kind of have to make the decision, the risk of proning and versus the benefit of waking them up. And it's really case by case. I do think that patient who's like 3 months into their ECMO run and their SATs are going and they're just not oxygenating them, I'm not sure how much benefit you're going to get from proning that patient. Like, that's just RDS, right? There's no A in there. We've transitioned away from the acute phase. So
Yeah.
I don't know.
Yeah, that's a great point that I just want to emphasize is that the benefits of proning are early on, right? When the lungs are still wet and there's not the fibrotic phase. The further out we go with
Mm-hmm.
our patients, the less likely that proning is going to help. And I see people trying it But then you start to, when we talk about risks and benefits, and the risks early on being less than the benefits, now we're really taking a risk on very marginal benefits of improved oxygenation. So good review there, Adam.
I think maybe a good, I'm just thinking, maybe a good indicator was like, how well did they respond to their last prone session pre-ECMO? If they responded well and tolerated it well, maybe that's someone you should keep proning after you cannulate. If there was like minimal benefit, maybe that's someone you should avoid it.
Gotcha. One thing, now that you're talking more about it, is if you have that patient, you take them, let's say they're not spontaneously breathing, you still have them on 15/10. Where do you make the decision to do something? And this is one of our questions, to do something like APRV maybe, or just skip over that and go right to a proning session? And these are all nuanced questions. You'll never find the right answer, but that's what the critical care lounge is really
That's
all
right.
about, right?
So I generally think APRV on ECMO is probably not a good idea. The reason I say that is these are the sickest ARDS lungs we have, and APRV's tendency for pneumothorax is certainly there. And once you give these guys a pneumothorax, and then you put a chest tube in, and then there's sometimes bleeding from the chest tube, and then it's this cycle of you're not going to recover. So I generally don't. The patient I think maybe is a good idea is, and I know we'll talk about kind of like the weaning off ECMO later, but is that patient who is somehow minimally ECMO dependent, and you think atelectasis is a huge component of it, and sometimes flipping them to APRV, doing an open lung approach really opens their lungs up, and get you over the hurdle.
But it's more like a longer recruitment maneuver.
Yeah,
Even though I
yeah,
don't really like that word, but like it's a more gentle recruitment. But there has to be a
yeah,
finite period to it. It's not like now they're on APRV for the duration of their care. It's a good point.
yeah.
It
We
also,
could.
Mhm.
I was going to say we can't be caught saying recruitment maneuver on today's medical education. That's like, come on.
Yeah, yeah, for sure.
I think that's fallen out of. But yeah, I agree totally. Like
Yeah.
that's it's the same thing.
And the last part, I mean, you mentioned all the complications. Is if you're keeping this person euvolemic and even a little on the drier side, then you start to run into problems with, preload to the heart with APRV more so, and now they drop their pressures and they're on vasopressors, and in a lot of ways it
Hmm.
moves you backwards. Now I know that there's some APRV gurus out there who are cringing and want to get in and have a comment, but not today. This is our show, so well, maybe we'll have those people on in the future. All right, brother.
Yep.
Let's go on and talk about weaning this person off of ECMO. When do
Yep.
you start to get that little glimmer in your eye, that little smile in the corner of your mouth where you're like, I think this person is turning the corner. Let's start pushing them. Not that you weren't pushing before, but you catch my
Well,
drift.
yeah. I feel like the patient just tells you. You walk in one day, they look at you and they say, "I'm ready, doc. Let's go." You just know, and the reason you know is it's all about compliance, right? So that's the best part to me that on pressure control in this scenario is their tidal volumes just start to creep up. They just start to go up, and then you realize, like, instead of 70, the next day it's 100, and then it's 150, and then all of a sudden, holy smokes, they're pulling 350 with a driving pressure of less than 15. That's incredible, right? So your peak pressure 15/10 is 25, and the tidal volume is 350. That you're cooking with gas. That's when you know that they're ready to start to wean. And you'll see it. The X-ray will clear up. Like it'll it'll be clear. And so how do I do that? That's when I switch back to volume control. So that's when I will go ahead. You don't have to. It's just I feel like we're more comfortable with volume control, specifically with ARDS, and we can kind of talk about the nuances of that. I like volume control in general in the ICU because it is a mandated minute ventilation. You set the tidal volume, you set the respiratory rate, the minute ventilation doesn't change, right? That's different than pressure control. Two things happen. Either the lungs get better and now all of a sudden I have volume trauma, or the lungs get worse and that minute ventilation drops.
Mhm.
And so I like volume control in general in the ICU because it's the lazy man's vent mode, right?
Yep.
And so I switch into volume control, 6 cc's per kg. Make sure that their plateau is acceptable on that, and then I start pushing the respiratory rate. into something like 18, 20. I don't really like if I have to have a respiratory rate of 26 to come off ECMO, I'm a little worried about the gas exchange, so I may hold off. But 18, 20, I think that's a good number. And they, FiO2 still down in the 50% range.
Yeah.
Then I'm thinking to myself, this guy's probably ready to push it.
That was actually my next question is, along with this comes your creeping down the FiO2 to see how they're handling it.
Right.
Maybe slight adjustment of PEEP if necessary, but not too much, right? Because then you're kind of, causing other sorts of barotrauma or barotrauma essentially if you keep
Mm-hmm.
dialing it up, right? So there has to be, they have to just look at you. They have to look right, and then you start creeping things down, creep down the FiO2. I like that approach. What about the circuit? What are you doing on the
Yeah, the
circuit?
circuit's
Best
great.
case.
Right. So generally now I'm titrating the sweep to pH, right? Maybe PCO2, but usually pH, because these guys all have developed either chronic respiratory acidosis, but more likely, well, they all have PCO2s that'll be in the 60s, 50s with a normal pH. And the answer could be, is that just from like chronic dead space, poor gas exchange, chronic respiratory acidosis, or is it compensation from all that Lasix you gave them? And now it's just compensation for metabolic alkalosis you've created. But they all seem to, right? So I target a pH 7.3, 7.35. We titrate the sweep down. Flow stays 3.5, 4 liters. I'm not too worried about it. I don't titrate the flow down. I personally, and now this is not many of my colleagues do, I don't touch the blender FiO2. That sucker stays on 100 for me always. I get the vent down to 40%. I'll go to 30%. I'll go to 21% for all I care. But I leave it at 100%. I just don't see utility in that, because what's going to happen is eventually the sweep is going to go to zero. They're going to be recirculating, which essentially is just a big loop-de-loop. There's no gas exchange occurring.
Mm-hmm.
And it doesn't matter what you have that on, 100 or 21 or whatever. It's not participating. It's 21%. Does that make sense? So that's how I do it.
It does make sense. I'm just curious though, as there's no consideration of how quickly you're going to wean them if you take their blender down to like 60% and you find they're not doing well, or it's 100, then go to recirc.
100 recirc, because I've also found, and this isn't always true, but usually the ventilation lags behind the oxygenation. So their oxygenation usually improves to a point where they're no longer needing ECMO, and it's really all about that CO2 removal that they need it for. Not always, but I don't know. It just gets complicated, because then you bring the FiO2 down to 80%, and then they have a hypoxic episode, and then the vent goes up to 60% because the nurse can
Right.
quickly titrate the FiO2 on the vent, but they can't. They have to call perfusion to do the other, and it's like, what's going on? So I just leave it alone.
It makes a lot of sense. I mean, I know it's not it's not the approach that everyone uses, but it makes sense in my mind, because look, if they can't tolerate it when they come down, you still have the ventilator once they come off. You're just proving that they can ventilate well. The oxygenation part you could still do with the vent. They've already proven that their gas exchange is better, right?
That's right.
Okay.
That's right.
Perfect. All right. So then next steps. Let's talk about this recirculation. So you made the decision, recirculation. How long does it last? And then what's your thought process? What are things that are very positive for you? What are things that say the person isn't ready just yet?
Yeah, I think that this is a field that is literature free, which is that patient who's about to come on enough ECMO, like what tells you that they're going to do well and what tells you that they're not going to do well. So this is actually a particular research interest of mine. So I'll plug it. If there are centers out there who are interested in this question, they should reach out, because I am forming a cohort to look exactly at this, because I'm very fascinated by it. A kind of decannulation scoring system. And so generally it's pretty obvious. We decide to recirculate, and my approach has been, we round on the patient, we decide to recirculate. I usually recirculate for 4 or so hours. I get an ABG, I see how they're doing. If they're doing well, then I say, okay, I'm going to decannulate tomorrow. I've just found this is the safest way to do it. So then I decided that the next day, today's Monday, Tuesday, I'm going to decannulate. So what do? I usually put the sweep on, maybe half a liter, maybe a liter. And there's no great, I don't know if this is like a witch's tale in the perfusion world, but they talk about the oxygenator having pulmonary edema, where if it's just recirculating and there's no gas exchange occurring, it gets wetted out and then it's ineffective. So some old school perfusionists like to have a little bit of gas exchange, a little bit of flow going through. So I'll put the 0.5 liters just to make everyone happy. And then what happens is at midnight, so this will be Monday midnight, the the sweep goes off to recirculation, right? And then at 6 a.m., the heparin gets held. If I'm feeling like I got to do it before rounds, 4 a.m. the heparin gets held, and then we pull the cannulas about 4 or 6 hours after the heparin's off. That's the approach.
Makes sense. Very elegant approach, very physiologically targeted. And then, is it just safe to assume once they're decannulated, their oxygenation might go up, their vent settings might go up as a result of that? But it's still going to be in the safe range because you've already been recirculating. You've already tested them out. Is that right?
Right. Ideally, it doesn't change at all, right?
Sure.
So most patients have a SIRS reaction within 24 hours. So nearly every patient has a fever within 24 hours after decannulation, and that is just normal. So I don't freak out over it.
Yeah.
There's one of our colleagues said, should we be giving everyone ANSEF before we decannulate? And I actually think it's really smart. And
We have
maybe we should. I don't know.
We have an orthopedist in the ranks now.
Yeah, that's right. She's ortho. Yeah. It's like, doc, they're already on meropenem and gentamicin, Vanco, and linezolid. He's like, yeah, but not Ansef. You got to kill staph.
It's interesting. Why do you? I would expect there to be a much higher surge response when you first cannulate them with exposure to the membrane and the new cannulas and stuff.
Mm-hmm.
What is your thoughts on why people show that? Because I've seen it too, but what is your thought? Is it just transient bacteremia as we loosen things up?
Yeah, I don't know the answer. I think I'm pulling huge cannulas that are kind of part of their body out, and I think that there's probably enough vascular insult that it pisses the gods off, right? And I think there probably is a similar surge response on cannulation. And this is so important. I'm glad you brought it up. Is that, remember, I'm controlling the temperature of the patient with the water bath. They're 98.6 because I told them to be 98.6, which we didn't talk about that. I'm obsessed with the diff and bandemia on patients on circuit because they don't have a fever. If your ECMO patient's having a fever, either your water bath is messed up or you're in deep trouble. And so I'm usually, even just bandemia alone is a reason for me to culture and throw antibiotics on. That I'm that concerned about it because we all know they're prone to secondary infections.
Absolutely. That's a great point. Yeah, bandemia is just one of those things that I'm always on the lookout for. And forget ECMO patients, any patient, like just be cautious of someone who's having bandemia. Okay. Any other thoughts? Any final thoughts? By the way, that was amazing. I like to just go through your brain, see all the different steps in a very logical way. And everything you said makes perfect physiologic sense to me. But is there anything else that you wanted to add that we didn't cover, or anything else that you think is just nuance that you think is important for people to hear?
No, I think that was good. I ultrasound everyone 48 hours later after the cannulas come out to look for DVTs. There's a lot of cool things in literature, like oxygen challenge tests you'll read about. You essentially put them on 100% of the vent, wait 30 minutes, and you check a gas. And if the PO2 is above 300, that tells you it's time to wean. The problem is that there's also it sounds so elegant, but there's multiple studies that say that doesn't really help. And I have found it just delays the weaning process by trying to do this. So I don't do that. But other than that, I think that's good. I like the question about LASIK strip. I would tell you, if I had the option, I would put every single patient on scuff, and I would just control I would control their eyes and O's with my dialysis machine, and I would not use LASIK, and I would not use the kidneys. Now, the nephrologists out there probably think that's crazy, because it is, but that would be easy. We didn't talk about that either. We run all of our CRT through the ECMO machine. We don't do separate cannulation site, which I think is there's there's we got a paper coming out on that pretty soon, so that'll be neat to kind of show you our approach to it. And there's some unique things we do.
Yeah. Yeah, I've seen when I was at University of Maryland, I saw one patient who was massively volume overloaded, and I just like my eyes like came out of my head when I saw just how fast you can, take off
Mhm.
ultrafiltrate off an ECMO circuit. It's impressive, and to your point, it just takes the guesswork of let's see what their kidneys are going to do today. It's like, no, we want 1 liter off, we will get 1 liter off, right?
Yep,
Yeah,
that's right.
well
That's right.
done.
I love it.
Well, my man, we've come to the end of our program. This was wonderful. I was looking forward to the show, just so I can pick your brain and just see where you're at. You're so smart with this stuff and doing a lot of research. If anyone is interested in reaching out to Adam, I'm volunteering you to be a
Yeah,
collaborator with any studies or any sites where they see an opportunity to research. Please reach out to Adam because these patients, uh, while we're doing more of it, still don't have a big enough N for a study. So the more centers we get involved, the
that's right.
faster we get the studies and the data.
Yep.
Yeah.
Yep. Should we? What's the best way? Should I plug it? Should I put my email, or how does that work? Or they reach out just to Recess X and you'll forward it to me? Whatever you
I
think
mean,
is best.
they can email me, they can reach out, they could drop something in the comments. You never know when you put your email up on social media, strange things happen next.
Ooh,
A prince from somewhere wants to give you $10 million, but first you
that's
have to
right.
give him a million
That's right.
dollars. Yeah, we got a question.
That's right. Should we answer this question? I think it's a good one. So it says, what labs do you look for on a daily basis on the ECMO patient? Okay,
Good question.
so normal stuff. LFTs always. I don't know how frequently, but I like to keep an eye on my hemolysis labs. I certainly change circuits based on hemolysis alone, not necessarily gas exchange, but hemolysis alone, because with hemolysis comes blood use, and with blood use comes infection risk, which comes badness. And so, of course, the circuit change is a procedure itself, and not all patients can tolerate it, but that's something I think about. And then they ask about chest X-ray. So I we didn't talk about final cannula position. That's a good topic too. We do get daily chest X-rays. Part of the practice is a chest and abdominal film, so you can see that tip of the lower femoral cannula. I do measure it. I'll say 11 centimeters sounds like a good number. That's usually about what you want. If they're too close, you get recirculation. Right? They both cannulas go bright red, and you check the PO2 pre and post oxygenator, and they're very similar. And then what else do I do? But if they get malpositioned, um, a better way to adjust is through ultrasound, subcostal. You want that tip to hang out right in the hepatic IVC. If it's too far down, the IVC is more likely to collapse and cause suctioning. So you want it right in the hepatic IVC where there's some structure. So kind of up, but not too close to the return cannula.
Well said. And then how often do you get your hemolysis labs? Because again, being part of the practice, I hear
Oh, sorry.
various things. No, it's okay. Just I'm curious what you do.
Uh, I think Billy tells you because you'll start to see your indirect Billy starts to creep up. Other than that, I think getting LDH haptoglobin maybe every 72 hours is
Yeah,
more than enough.
that's usually
I think that's probably fine.
yeah, yeah. And then anything else that you need to see daily on that ECMO patient, like I'm chest X-ray you mentioned, but anything else besides the routine labs to look through? Anything that's like I need this extra lab as part of
I don't
Adam
think
brings you
so.
mentioned.
I
Okay,
mean, check your cannulas every day.
yeah.
I do my own dressing changes. I sometimes those cannulas are loose and you got to throw some more sutures in them. But yeah,
Well done, my friend. Well, Adam, well done to pull out this episode kind of on the spot here with our guest. Having a prior commitment, but you knocked it out of the park. I mean, you could talk about this stuff in your sleep. So thank you for letting me pick
I
your
love it.
brain. Yeah, man. And we are gonna get back on track. We've been sort of a little bit off schedule, but we're getting back on track. And the other thing we want to let you people know is that we're going to be doing a few more Instagram lives. So I bring that up for two reasons. The first reason is because we're just trying to bring you more content in a shorter format in ways that are more digestible than these longer format shows. But the second reason is we do have to tell you where we are on social media. And Adam is at underscore Papa Green, right?
That's right.
and
That's
uh,
right.
and I'm Critical Care Now, so you can find us there. So follow us on Instagram, so that you can be aware of when we're going live. But we will try to advertise those, so you can put a note on your calendar. With Instagram, we can actually put like a countdown, just like we do here, and you'll know exactly when we're going live. I see some questions popping up, but and I'm getting smaller. Why am I getting smaller? But what any questions that you want to grab, or should we just bounce out?
No, I think we're good. I think
Okay.
we're good. I mean, reperfusion cannula has to do with VA, and we were focusing on VV, so less of an issue here. But I'm glad everyone liked it, and I hope we get more of this.
For sure, for
We
sure.
could talk about ARDS and ECMO all the time.
Absolutely. And we'll maybe the next thing we'll do is we'll talk a little bit about mechanical support. We'll talk about some VA type stuff.
Hmm.
We can get Dr. Gala on. He would be a great guest.
I would love. I would
Yeah.
love to get Gala and Minikata on and talk
Oh yeah.
about Impella 55 CP, when you switch to VA, how you wean VA, the concept of LV unloading. We could go on and on. It would be an awesome discussion.
Done. We're gonna do it. All right. So Adam, looking handsome as always, and the hoodie just augments your beauty. Thank you for wearing it.
Thank you.
And don't forget to like and subscribe to the channel. Stay tuned. We promise you we're going to be doing this a little bit more regularly. Follow us on Instagram. And with that, I'm going to say goodnight to you, Adam, and I look forward to chatting with you soon.
See you, everyone.